Hi, everybody. Welcome back to Research Literacy 101, the first session, and this is our second content session where we're getting after the evidence-based spiritual care, evidence-based chaplaincy as it's applied, and what we mean by validity. To kind of frame things historically, many of you are familiar with George Fitchett, now the Director of Transforming Chaplaincy and the founder and co-director with Wendy Cadge back when Transforming Chaplaincy began. He has done research in the past, including what I'm going to talk about here in a second, with another ACPE educator and the Associate Dean at Virginia Commonwealth University here in the United States in Virginia, and his name is Lex Tartaglia. So together, along with others, did this study looking at the prevalence of research literacy among the chaplaincy training programs, or the ACPE, or Association for Clinical Pastoral Education. And here's what they found. Notably, that only 12% had intentional and substantive research-related curricula. So a pretty low number. In fact, recently I asked George and Lex if they would consider redoing the study. They said yes, but hopefully in a couple of years after they look at how much of an effect transforming chaplaincy has had through many CPE programs receiving research literacy education, and then hopefully those chaplains being out in the field. So I'm from the United States, and my board certifying organization is the Association for Professional Chaplains, and these are the standards by which I am held to or uphold. And Standard 12 is about research. The language here probably isn't too much of a surprise to you. You can see the document wasn't published that long ago, so a lot of people like us are in this research world saying, I want to do more of this because I think it makes sense. So speaking of us chaplains, we like to disagree about, I think, this particular topic among others. That being, is our profession primarily about outcomes, or is it primarily about our presence? And I'm among the group of people, and those that I will talk about here in the slides, I think would say it's about both. They go together, they always will. But hopefully we keep having this robust dialogue that's kind of pictured in this slide. And to begin this dialogue, and represents it well, is Steve Nolan, a chaplain, a researcher, a scholar out of the UK. So he has this recent publication called Lifting the Lid on Chaplaincy. If you have not read it, it's a nice read. It doesn't get into the deep minutia of quantitative findings. It's a really accessible article, and it gets at the heart of what we are about in chaplaincy. And if I had to be pinned down, I think Steve Nolan falls a little bit more onto the side of presence. If you were looking at the teeter-totter or the balancing out of presence and outcomes. If you don't know what Steve Nolan looks like, here's a photo. And I titled this slide kind of, what is this stuff about presence and what some people will pull together with presence, being with or process-oriented way of chaplaincy? How is it juxtaposed with those who perhaps have a more avowed outcomes framework? So first thing I'll say is actually down here is Steve Nolan's not a big fan of calling it process-oriented chaplaincy, and he explains why. But he says it's not an either or, it's not a false dichotomy. Neither, but it's more of this sense of a both and, that these outcomes and presence have to go together. They always will for us in the chaplaincy world. But here are a few other things that he says in his article. Number one, he refers to this caution about the McDonaldization of chaplaincy, which gave me a good laugh, being from the United States, the birthplace of McDonald's, because I've not heard that term before. But what he meant by it was that we should not atomize. We shouldn't break down our chaplaincy profession into these series of interventions, into the minutia, such that people can just kind of order us off the menu, as it were. He says it needs to be more of this foundation of who we are as a spiritual practice. And I think it's perhaps somewhere maybe in between, because research is about getting into the details, that you have to kind of narrow down your focus enough to kind of get the outcomes of what you're after. So Steve Nolan, I think wisely in his article, says we need to, using this metaphor of the box, we need to look inside the box of kind of who we are as chaplains and find that evidence. And we're great storytellers. We are great story listeners. That's the language in which that we dwell. So as the keepers and the curators of that data, we need to get it out there. And to do so, we need to publish cases. And that's part of the method to the madness of why we ask you to write cases. The second scholar I'd like to introduce you to is Annalika Dahman in her recent article, which was also published in the Journal of Healthcare Chaplaincy. And if you had to pin Annalika down, actually you don't have to pin her down, she says it in her article, that she leans more to the outcome side while still honoring the importance of presence and how we do that in our work. So she looked at 22 chaplaincy-specific outcome-based articles. And I'm going to read this next quote because I think it's that good. We concluded that chaplaincy is necessarily outcome-oriented because it is aimed at supporting some change for the better toward these goods. Hence, processes are directed toward outcomes and outcomes guide the processes. She ends her article by saying some things, including that chaplaincy needs to continue to be in this world of looking at what the outcomes are as they guide the processes and vice versa. And to do that, we need to use mixed method designs. And why is that? So as we'll talk more about, and my guess is you have this intuitive sense that quantitative studies are about the numbers, the measures of association, and the qualitative studies are about honoring the voices of the people that are being studied, whether it be staff or patients or families. And together, we get a mixed methods design. So we get the numbers and we get the voices. And to me, that's relatively brilliant. Like Steve Nolan, she talks about this black box of chaplaincy, like what's inside that box, and what I've heard other people say is that secret sauce that we chaplains have. Steve Nolan, I think, captures it best with an illustration in his article, the one that was called Lifting the Lid, when he says, many of us chaplains are familiar with the scenario where you might be walking down the hall of a hospital. A nurse, he or she, stops you mid-hallway and says, can you please come in and see this patient or family member? They're having a really hard time. They're declining interventions. They're not wanting to move forward. They're wanting to leave the hospital. We've tried everything. Can you please go in and see what you can do? So you go in and you do your chaplain thing and you come out and the nurse says, how'd that go? And you respond, I think it went pretty good. Then the nurse goes into the patient and they're saying that you're the best thing since puffed wheat. They're ready now to move forward with the interventions. They feel calm and at ease with what they have in front of them with their illness process. So the nurse, of course, comes back to you and says, well, what did you do? And you say, well, I was just being me. I was just being the chaplain. So I am among the group of people. My guess is because you're in this class or this course, rather, that you're among the crowd of people that says we have to do better. We have to say, well, what specifically did we do? And to get at that specific, what did we do? We just need to do more of these case studies. We'll get at why that is and more throughout this course, but it gets to that evidence-based pyramid. Again, case studies are at the bottom. We got to fill up the foundation so we get a better sense of what do we need to study in a more refined way, in a chaplaincy-specific way. So speaking of all things chaplaincy-specific, here's another third scholar in the chaplaincy world to lift up. Sadly, Kate Peterman is retiring from where she works at the Mayo Clinic in December, I think is what she told me. She's done some exceptional work. It's the punchline of this particular PowerPoint slide around life review, or what some other people will put into that realm of intervention called legacy work. So in legacy work, there's a lot of published things out there. I'm just going to highlight a few. One is from Bill Breitbart. He's a psycho-oncologist at Memorial Sloan Kettering. He came up with something called meaning-centered therapy. It's getting a lot of traction, but he was avowed in saying this is not for chaplains to do. Okay, so we can't generalize because we weren't a part of the research team, nor we were considered as people that would offer this intervention. On the other hand, there's this other psycho-oncologist who is in Canada, but trained with Bill Breitbart. His name is Harvey Chachanoff. Many of you might be familiar with his work around dignity therapy, a lot of articles, a book, including a recent article in which George Fichette happened to be one of the investigators. And chaplains were people that were considered those who could offer the intervention. A third realm to look at is for anybody to kind of do this work. So Barry Baines is a physician. He's out of my home state here in the United States of Minnesota, and he harkens back to his own faith tradition or ethnic or self as a Jewish person, and the tradition of the ethical will that I, as a human being, not only want to transfer my possessions or what material wealth I may have, but the wealth of who I am as a human being, my values, my morals, my ethics, the essence of what I, not the what, but the who I am. So Kay Peterman comes along and gets some funds and says, well, let's do this thing called Hear My Voice that is chaplaincy specific and get some outcomes. So if you are an acute care hospital chaplain, you've got something that's out there that says, this was for us, we can do it, and there's evidence to suggest and support that that's possible. So if people come along and say, you can't do that, that's for social workers to do. Oh, no, you can't do that, that's only for psychotherapists. No, there's actually evidence that says chaplains do this and we do it good. So I like that. Let me give you another example. So there's a chaplaincy specific article on my left and one that's more broadly kind of religious, spiritual on our right. I'll start on the right. So out of MD Anderson, there's this great research team. They're always churning out amazing articles and evidence. And there's this one. You can see the title. It's about spiritual distress. And on this research team is a chaplain, which maybe like you, I think it's an important thing to always kind of look for when they're endeavoring to look at all things religious and spiritual. No surprise, it's a palliative care article as well. So in the United States, we have these national consensus guidelines that guide us, and these are kind of broadly governed by these 8 domains of palliative care. Domain 5 is about religious, spiritual, existential care. But as you probably know, palliative care, it says chaplain is the specialist, but we're all responsible for all 8 of these domains. So it makes sense that paying attention to the spiritual, religious distress is something that all team members in palliative care need to adhere to. So this sort of is about chaplains, but not exclusively. Whereas this article on the left is pretty much about us. One could arguably say chaplaincy is not in the title, but the first 3 authors are chaplains. Stephen King is out at Fred Hutchinson Center out in Seattle, Washington. George Fichette, of course, you know. Pat Murphy, recently retired chaplain and biostatistician from Rush that used to work a lot with George and co-publish with him on a lot of things. This was cool because this article was a response to the National Cancer Comprehensive Network, or the NCCN, coming out to the United States outpatient cancer sites to say, if you want to be certified, you have to now show that you do screens for all these dimensions, including spiritual, so emotional, psychological, nutritional, and now spiritual. But absent in the data was what were the best ways to screen for that. So this is why it drove this research, and they came up with what the 2 best questions were. So just this gets at what we're after is the next thing, and that's about validity. So this article, the one on the left right here, was I used it for a journal club, and it some people saw the questions that, again, I commend the article to you as well, came up with these 2 questions at the end, and they said, I wonder if I could use that as a screening tool in behavioral health. Well, you could, but it wasn't designed for that. It was designed to do what it was supposed to do in advanced cancer care, and thus we get into this world of validity and reliability. This is a fun quote. It kind of has a small riddle kind of format to it, and yet it's very accessible, but this is the sentence that I want to draw your attention to here at the end. But if a test does what it is supposed to do, that's being validity, then it has to do it consistently, reliability, to work. So again, going back to validity, they were looking at advanced cancer population. Does this screen this well enough? Is it valid enough to say that this is what we should do? And they came up with the conclusion, yeah, this is the best tool we have that they offered. So let me go to this next slide and drill down a little bit deeper on what we mean by validity. So there are these 2 terms. There's internal validity and external validity. And as you might imagine in the research world, you've probably seen it in other articles, these terms get even broken up into further branches. But for the purposes of time and staying with this, here's this quick review. Internal validity, does it do what it's supposed to do? And then we've got external validity. When we're talking about generalizability, we're talking about a quantitative study. And generally, if you see the word findings, that's also related to a quantitative world. In contrast, we have the world of qualitative research, where we say, I'm not so sure this data can be transferred from this population to the other one. So instead of generalizability, you see transferability. And instead of findings, you see the term results. Does this data show the results that we're looking for? There's some references. Thanks very much. Look forward to session 2 with you. Again, please send me any questions. Contact me for some dialogue. Look forward to talking with you.